All right, we are here today with Dr. Anna Folckomer, and I discovered her coursework with her partners probably a few years ago, and it kind of brought a lot of different things I dabbled in NKT and DNS full circle, which is some our different continuing ed courses that I took through my chiropractic work, and I just love the integration of all those different concepts in more of a usable way for the office. So I'm going to hand things over to her so she can introduce herself and give us a little background.
Okay, perfect. Well, I'm very happy to be with you today. Hi, I'm Dr. Anna Folckomer. I am a licensed acupuncturist and a board certified herbalist and a clinical anatomist. So prior to that, I had a background as a professional dancer, which is actually what brought me up to New York, which is I'm based in the New York City area, and sort of sent me on this wild journey of understanding what this human tool is. So I have a clinical doctorate and a master's degree in traditional Chinese medicine. So that is, all been part of the interesting journey. If I could go back and redo it all over again, there isn't a single thing that I would do differently.
Oh, awesome. Yeah. So when you started your company or the program and the coursework, how many years ago was that?
Well, let's see, I think it was 2013, I believe. We were up in Orangeburg. Dr. Dooley was teaching at Dominican College for their DPT program. Mm-hmm. And Danny had just finished doing some illustrations for Dr. Frankie Scally on the myodural bridges and the suboccipital triangle. Mm-hmm. And Frankie, I believe, was a friend of Kathy's, and he had introduced Danny to Kathy because Danny was trying to go into this world of medical illustration, but unfortunately, in order to be, there's very few medical illustrators. I feel bad telling his story, he's not here. But in the world of medical illustration, they basically need you to be pre-med or, some sort of clinical equivalent. It's not something typically designed for artists, with the creative track only. Mm-hmm. And so he had figure drawing and things like that, but he didn't really have the hard biosciences that they typically need in most medical illustration programs. So Frankie had connected Danny with Kathy. Kathy was enrolled with me at Pacific College for a little while. And then she just, she opened up the lab for some assistantship. So I went up there to help her. And then Danny was there to kind of audit her class. And Danny and I met through Kathy. And it was the greatest day really of my life, because they were dissecting the forearm. And what gets a little bit tricky about this is when you have a prone cadaver and they're in prone forearm position as well, and you're trying to kind of sort out which is the flexor compartment, which is the extensor compartment, and then you get that weird little twist of the radial head that just sort of takes all the anatomy and it goes like this, and then the person's also facing down. Yeah. And everybody, at some point there's no skin anymore. You kind of forget which way is up, which way is down. And so the students were just sort of it is a really tricky thing to dissect. I'm sure you've probably done it as well. And Danny painted it on my arm. He was like, hey, maybe we can clear this up. So he painted it on my arm in the lab, and all the students left their bodies to come watch me kind of just do this. Mm-hmm. And we were like, oh my God, this is crazy. And mm-hmm. Kathy's the most enthusiastic person in the world. So she was like, we can go around the world doing this. And I'm like, okay.
Yeah, I guess I should have pointed out the difference between the courses I had done before and I feel like what makes your stuff so unique is that you bring it full circle and give those clinical pearls and stuff that you're going to see in your office and that kind of connection. But to the So other people should have mentioned that you do have this elaborate way of presenting it with the painting and stuff like that.
Yeah, you know, I mean, clinical relevance is not a new thing in medical education. It's a tricky thing in medical education. There's actually, I was reading a Medscape editorial about it a couple of weeks ago that I resonated, and it like made my heart so happy, but also so sad at the same time, where there was a nephrologist who was like, I want to go back and reteach and restructure how, nephrology is taught in medical school, because you learn it from this very basic A&P and then pathophys way.
Mm-hmm.
And then when you get in front of a patient, it kind of all flies out the window, and there's a clinical application that it creates a very big gap. Mm-hmm. And so he was writing about how he sort of like wanted to face this head on and change the way that it was taught through clinical pearls, and then sort of working backwards. And ultimately what happens is it doesn't prepare them for their boards, because their boards are very much based on academic cliches and, you must know this, you must have these word associations and stuff. Yeah. And so, it sort of came full circle in the sense of like, well, the reason why clinical applicability isn't always taught in medical education is because it's not the most accurate board prep. And I mean, we all, Kathy and I both teach in institutions. We run into that problem all the time. There's like the things you need to know for a test, but it kind of sets your soul out a little bit to have to teach for a test. Mm-hmm. And then to, feel like you leave a program that you've paid really good money for and have gotten a great education from, mm-hmm. but don't know how to translate that to a body. And so I think that we had all experienced that as teachers and students enough to, know that there's a problem there, and know that like, okay, it has to be this really delicate balance of clinical pearls, but then also like foundational kind of, these are some sort of laws of this subject matter that you have to know. Mm-hmm. And so it's a thing that we're constantly evolving. So we've been around this is our 7th, 8th year. And we're still trying to find what that delicate balance is, because I think it can be really tricky. It's, mm-hmm.
Yeah. And that's funny that you say that in the graduate school level, because I literally just had a patient this morning that's a 2nd grade teacher, and she had just moved from 4th grade to 2nd because they start testing, I think, at 3rd grade. And she was just burnt out after 20 years of teaching to a test, that she wanted to get in a grade that was before you have to worry about teaching to a test. So it goes from grade school all the way up.
It totally does. I mean, it's a frustrating thing. And so we're not really confined to assessments like that. But I mean, we understand that it's not, I don't want to call it a deficit, but we understand that what people are typically coming to us equipped with is that background. Everybody who's been through formal training, everybody who has a professional license at some point was taught subject matter with an intention of being able to also pass a test. And so that does sort of, in the real world, leave some holes. And we've taught this material on 4 continents now, and it's consistent everywhere. This is not a United States problem. This is not a Canadian problem, North American, European, whatever. We see the same things in Asia and Australia. Mm-hmm. So, it's fun to be able to go, okay, hey, listen, the point of school is to get you your license. And then what you do with your license is really sort of up to you. And so it becomes this really beautiful blend of art and science, where you can, take a creative spin while you're tackling that clinical applicability. Mm-hmm. And I think that that's what we're currently committed to, and having a lot of fun with, for sure.
Yeah, definitely. I get a lot of patients that'll say, no, I've been to other chiropractors. This isn't at all the same experience. And I'm sure you get that as an acupuncturist as well. And I think what you're saying is when you graduate school, you have these very basic tools, and it doesn't always translate really well with it when you have an actual patient in front of you. So definitely. But with the with you being an acupuncturist, I feel like it's probably even a little more different for people. How do you integrate the two practices?
Mm-hmm. That's been a fun thing to kind of figure out that did not happen overnight. That's something that I, constantly tweak all the time. But what I found, there's research articles actually that suggest, there's an anatomical research articles that suggests that early acupuncturists or early anatomists were the ones that set out the body maps and the meridians and things like that.
Mm-hmm.
Thousands and thousands of years ago. And I find that to be really interesting and validating, because when I've got to go into the lab in just a little bit and start dissecting for an upcoming cohort, and it never fails to impress me when I still locate all my points on cadavers, because I still want to just make sure, you do your points, you locate them, and then you're like, what's there? Why does this thing do what I know that it does? I don't need convincing that my medicine works. But what I want to know is how many ways I can explain it. And, I think that a lot of times acupuncture theory falls a little bit victim of translation error. It is primarily, it's very poetic medicine. It's rooted in Eastern philosophy, which we don't have an understanding of in Western Hemisphere typically. It is an agricultural society, or was at the time of writing. And so a lot of things are written kind of like how you would read an almanac almost. Mm-hmm. It's very much about kind of forces of nature and things like that. And so it just has this really lovely, beautiful, poetic spin on it. But then when you really sit down and read it, you go, oh, they're just talking about this. And I often tell people, well, if you speak two different languages, that when you translate one of those languages into another, like literally translate it into another language, it won't make sense. But you don't invalidate an entire language just because it didn't make sense in the way that you translated it. Mm-hmm. And I think that is a problem that Chinese medicine can typically have in the United States or in the Western world. And so for me, it was kind of more about like understanding something in that language and then looking to it in the language that people will understand, that I can communicate better with other physicians and my patients, because, this isn't 2000 years ago in China, it's Midtown Manhattan. And so I have to, be able to speak to doctors at Mount Sinai and NYU and HSS and my patients, many of whom are also doctors. So I think that for me, when I dissect, I'm constantly thinking about the Chinese medicine of it. And I look at why these points do what they say that they do. And it always pans out, it's really fascinating. You have to really look, and I feel like it became the work that I started to devote my life to, and never imagined that was going to happen in a million years. But you do start to see, oh, wow, that's how they knew. Oh, that's how that, okay, that makes sense. And and it reinvents this material that I'm already in love with in a way that is just fascinating. And so it's something I teach for the acupuncture school now. It's one of the places that I work, and so I try to bring that spin on it as well. But essentially, I will use an overlap of doing a good quality movement assessment and picking out points that I feel are appropriate for a patient based on my assessment, and then kind of overlapping that to their Chinese medicine patterns. Mm-hmm. And just finding where kind of creating a Venn diagram in my head and finding where the overlap is, and that's their point prescription. Mm-hmm. And that's how a lot of MDs who are also acupuncturists tend to integrate their work as well.
Oh, okay. And do you have a pretty good relationship with the medical community there and everything?
Yeah. Oh yeah, for sure. I mean, I have definitely gone to surgical consultations at HSS and sat at that conference table, and argued with a couple of surgeons and GPs as to why, I think this procedure is going to be appropriate or inappropriate. And they're like, why is that little lady in here? Don't worry about it. Just listen. I do tend to weasel my way into things.
Well, that's good. I mean, I like that collaboration aspect of things for sure. And with your Immaculate Dissection courses, who are the people that usually come to see? Obviously, acupuncturists and chiropractors, but
in terms of who takes the coursework,
mm-hmm.
Well, that's a really cool thing about it. We've had the widest range of people that have come. We get a lot of course, we do get acupuncturists and chiropractors. We get massage therapists, Pilates instructors, yoga instructors, fitness trainers, physical therapists. We have gotten MDs. We've gotten osteopaths. We've gotten we had a dentist. We have an equine therapist in England who's taken all 6 of our levels.
Huh.
And then we get people, it was so great. Like a couple of, I guess it was probably last January, we were in class and I was talking to this woman who was taking the class, and she had really great questions. And I said, what kind of therapist are you? And she said, oh, I'm not a therapist. I work for Amex. And I was like, whoa, really? That's so cool. She was like, yeah, I've just had this knee problem that nobody can figure out. And I start to just do research on my own, and I happened to find you guys. And so I figured I'd come to a class and see if I could learn more about myself. So we have patients that take Immaculate Dissection because, since Kathy and I are both clinicians, but also teachers, we teach our patients just like we would teach our students. And I think some people get the itch for it, and then they're like, well, I have to take this coursework now because I see that this stuff works for me, and I want to know a little bit more about why. And we can only talk about so much in a session.
Mm-hmm. So the way do you want to talk about how you split your courses, the different 6 levels?
Yeah. So we have 6 different courses. They're not really in chronological order. The only reason why they're labeled 1 through 6 is because that's the order that we made them in over about 5 years. But we have a core concepts class. We have a lower extremity class, upper extremity, and we have a head, neck, jaw, intrinsic hand, which also includes hyoid. We have a peripheral nerve entrapment, which is really interesting. We're teaching that one this weekend. And then we have a movement subsystems course, which is based off of Leeming subsystems work. We didn't obviously make up the subsystems, but we don't feel like people have paid homage to it. And in terms of clinical applicability, he's a phenomenal researcher, but we wanted more people to know about it and get their hands on it. So that's level 6. And then we have, during the pandemic, we started a collaborative program, which I really liked. It's something that meets roughly once a week for 1 hour only, because I feel like, when I started to notice that there were people who were coming in who were like, well, I'm coming in because I want to know more about diastasis recti, so I'm going to take core concepts, or I'm going to take lower extremity because I want to figure out my knee. So when I realized that we were getting this group of people who were very much just on their own journeys and not healthcare practitioners, I sort of thought, well, wouldn't it be interesting if we could just talk about topics, because the questions start to deviate every single class. It really, like, whoever's taking your class, if it's a bunch of trainers, if it's a bunch of chiropractors, if it's a bunch of Pilates instructors, you're never gonna, even if it's the same level, it's never gonna be the same class because of the questions that people are asking. And I mean, we have 15 hours of that, but I feel like it was hilarious. We go to LA and all of a sudden we're talking only about breast implants. No offense, LA. But it was like every question was about boobs. And we were like, these are great. I mean, they're great questions, there is surgical implications that we should discuss. And there is force transfer into the shoulder that we should discuss here. But we found that we were getting so many great questions that we didn't necessarily have the space to answer. So we thought, wouldn't it be great? And wouldn't it potentially bring in new people, especially now that everybody's at home more? We could just pick one of those things and talk about them for 1 hour a week. And I think it's been very successful. I think it's been a lot of fun. It's definitely kept us on our toes because we prepare a ton of research for it.
Yeah.
Just so that we can, thoroughly discuss the subject matter. And they've been about everything, migraines, menopause, stretching, blue light therapy, psychedelics, kettlebell swings. This week's is on ulnar nerve entrapments. I mean, it's been all over the place.
I did the year collaborative that first year, and I agree. It was truly impressive, the amount of information per week, the preparation, the notes with it, and all of that. And I actually thought to myself, this would be good for those patients who really want to know the why behind what's going on. Some patients don't care and they're like, just fix it. But then you get the patients that want to know, and you can just surf through the list and pick out the ones that are applicable to you or interest you. And you had such a wide, vast variety. And like the diastasis one, that is pretty applicable to all the people that I deal with. But your core course, I've done your core course in your lower extremity, and I just started the upper extremity. But man, I feel like the core one can be used on so many people.
Yeah.
Everyone.
Yeah. I mean, we don't require people to start with core. But we find that people who don't start with core get very, very happy when they finally take core, because they're like, oh, okay, this is where it all sort of starts and ends, really. So, I think that was the first one that we made, and that is the one that we definitely have the most experience with. But it is the one that, I mean, even when you start talking about something like an orthopedic or like a regional exam, right? You never can even really talk about that region unless you've cleared the axial skeletal system, essentially. But so, we find that it's a treatment limitation. Some of that is bureaucratic. Some of that is laid out by insurance companies that say, if you have an elbow problem, you really need to just be treating the elbow. Yeah. And it's like, well, what if it's an elbow symptom for a neck problem or shoulder problem? And so we've tried to create coursework that can help people have sort of an assessment protocol. One thing that none of us like are treatment protocols. We love assessment protocols. And so I think that, because we get a lot of people in our offices. I'm an acupuncturist, for God's sakes. I'm not the first person somebody's going to see for a problem. I'm like the 10th person. So, by the time somebody comes into my office, they have failed treatment protocol. And I see why. It wasn't a thorough enough assessment. So I don't think that there are unfixable people out there. I think there are people who just haven't been treated holistically enough and individualized enough. And so we thought if we just laid the foundations of what sort of should be happening and then teach people how to assess that, then it's something you can integrate into your care, even if you are confined to treating that elbow because your clinic said you got to treat that elbow. Like, okay, we're going to treat that elbow. We're going to do some breathing drills with it to make that stick. So
yeah. I would recommend your courses to anyone that's interested in the body, essentially, or any practitioner that is like a movement practitioner or within that realm, whether it be Because you don't even like, I'm very tactile in my profession and I am able to touch people, but I know there are some professions out there that take your courses that aren't allowed to touch people, but you can walk them through some things and help them do the stuff on their own, kind of a thing, which is nice because, when I first came out of school, I did a lot of active release technique, and I think I would have to retire after not very long because you're just throwing anything against the wall to see what sticks, and you end up treating a lot of stuff without pinpointing what is actually working, and you can burn yourself out physically, I think. And this is much more efficient at finding the source of what the problem is.
Well, and it's nerve-wracking too. I mean, as I find that some acupuncture, the thing that makes me bananas about it, that like is the whole reason why I have gone back to that school to teach, is because, in acupuncture, we're supposed to be the pattern people. We can tell you 35 reasons why you have a headache or diarrhea at any given moment. But then you get a knee or shoulder pain that's like, here's a 6-point prescription for that. And you're like, what happened, pattern people? Where's my 35 patterns for why my knee might hurt? Mm-hmm. And it felt like it fell short a little bit. And then, so, at the very least, people come into your office as an acupuncturist because their back hurts, their neck hurts, mm-hmm. They know acupuncture as pain management. And I feel like as a community, we drop the ball on pain management and we start to treat patients like dartboards, and I have a problem with that because I think that that's not the way that we're taught to think. And I think it's not the way that we are, I don't think it's the way that material is laid out classically. And so, it was kind of like, well, there's a pattern here too to discover. And so let's find that pattern and treat it. I don't feel comfortable doing things to my patients that I can't offer an explanation as to why it is or isn't working. It doesn't, I can't manage patient expected outcomes like that. Mm-hmm. I don't want to just put in a bunch of needles and kind of cross my fingers and hope for the best. Mm-hmm. Because I feel like when you get into that mindset, your patient like gets better sometimes and then gets worse sometimes. And then you are, you're holding your breath when they come back to be like, how would you feel after the last treatment? And, it really could go any way. And I don't like, that's not comfortable. I would rather have something that I can be confident with and really understand and say, oh, okay, here's why you're experiencing what you're experiencing. And here are the things that we can do about it. And it just makes it a little bit more digestible for not only the patient, but for the practitioner as well. Mm-hmm. And then it has utterly taken guessing out of my work. I never have days like that where it could go either way, but it's just not something I have to worry about because it's very assessment driven. Mm-hmm. So, I think that even if you're not a tactile practitioner, at least you have an understanding as to why something is the way that it is, and you can inform and educate your client mm-hmm. to how to help themselves.
Mm-hmm. Definitely. Now, with chiropractic, there are, if every chiropractor you go to is going to be different because there are so many different techniques. And, just like with Immaculate Dissection or DNS or NKT, you've got like lots of different disciplines practicing it. But with chiropractic, you could have someone doing activator or CBP or Gonstead, all different types. Or is that the same way for acupuncture? There's all different. Okay.
Yeah, for sure. I mean, I think that regardless of the type of acupuncture you're practicing, we have 5-element practices. We have people who practice a little bit more traditionally. There's Korean acupuncture, there's Japanese acupuncture, there's, it's kind of all over the place. Mm-hmm. But what is still present in all of that is getting to the root of the problem. And there is this deep commitment to understanding a person's constitution and understanding the root cause and not just treating the branches. Mm-hmm. And And I think that that's what makes Chinese or, traditional medicine very successful. However, it still can attract people in. And I think there's this need in our society to quick fix symptoms. And so I think that that is part of the reasons why people have sort of deviated a little bit from a pain management perspective of just like, well, let me just downregulate nociception in this area and needle it.
Mhm.
It's like, okay, well, but that just forfeits all of your pattern rules, regardless of what, school of thought you're coming from.
Mhm. Yeah, definitely. Real quick, I just wanted to get your take of how you would, since I work with lots of pre and postpartum patients, how you manage them in your practice and that kind of thing.
Yeah, so it really depends on, where they are in their journey. I do work with a lot of fertility patients. I've been present at many home births, and we definitely pick the pieces right back up with postpartum and that whole fourth trimester.
Mhm.
So I make sure that anatomically they're set up for success. There is a fair amount of gut pressure management that has to occur, whether you're trying to conceive, trying to prepare for labor and delivery, or trying to, make sure that your body can find its equilibrium and its sort of stability points after your body's been flooded with relaxin and your ligaments are still
Mhm.
that sort of postpartum phase. So, I mean, even like 15, 18 months later.
Mhm.
Um, so I think that for that, it really, the rules are pretty much the same. We like to say in Immaculate Dissection that no one gets a pass.
Mhm.
Um, and we, I mean, labor and delivery is the strongest thing that many of us will ever do in our lives. So we want to make sure that someone can minimize complications and side effects of that by teaching them how to manage gut pressure, because your center of mass changes when you're pregnant. Like, your body isn't your body anymore,
Mhm.
and not for a while. So and it kind of feels like that too, I think, for people who are going through fertility treatments, where they just really feel like their body's being manipulated in these ways for for a particular purpose. So, just managing the way that we move things throughout our body. You can call it chi if you want. You can call it intra-abdominal pressure and force transfer. I think there's a million ways to describe it. But it is a period where there's so much that changes. And if you don't have a basic understanding of what needs to happen, it's very difficult to keep up with those changes as they're happening.
Mhm.
That's what I like to, that's my baseline approach.
Mhm. Especially with that shift from, you gradually get bigger as you're, about to give birth, but then you give birth and it's like this negative space that is all of a sudden there.
Yeah.
But and I've never heard about the gut pressure with fertility, so that's interesting.
I think it's really interesting for the male partner, if there is a male partner,
Mhm.
because so often I have seen women go through 5 and 6 rounds of IVF, and no one ever asked what the morphology, motility, and fragmentation of the in the count of the sperm was. And that's a gut pressure issue often, and so if you can't get gut pressure down into the pelvic cavity, you can't stabilize the pelvic cavity. You've got it moving around in ways where you are operating at a deficit for being able to get blood flow down there. If you can't get accurate blood flow and adequate blood flow down there, your chances of implantation are way off. Your chances of being able to regulate the sperm temperature, which then has an effect on count and morphology and motility and just general health, that's going to be something that comes really from the abdominal wall. And so if you can't manage that, then again, your chances of conception are going to be much lower. Not to oversimplify all cases, because I know fertility is a very difficult thing to practice. those are my most difficult patients for sure. But when you're throwing all you've got at a problem, like, why not look at this? It's only going to help.
Yeah.
And even, once you do get pregnant, you have to have that gut pressure management to prevent tearing and diastasis and just general pain management when you go through the entire pregnancy and labor and delivery. So it's just a conversation that I think can start very early on.
Mm-hmm. That's awesome. Yeah. Yeah. Awesome. Wow. That is a really awesome look into how acupuncture can be for all different types of problems, but then also how you include the movement aspect into it. And again, for anyone listening, their courses are amazing and really bring things full circle for any movement professional or patient or person that wants to learn more about how you move and that kind of thing. So thank you so much. I know you're so busy as you teach in both the academic setting and continuing ed and have a practice. I don't know how you fit it all in, but thank you so much for doing this interview. And I'll put all your not contact info, but your website and everything in the comment section. So thank you so much. All right. Well, have a great day.
Yeah, you too. It's really been wonderful speaking with you. So thank you so much. Be well.
All right. Have a good one.
Bye.
Bye.